Welcome. In this short video, we will provide you with a basic introduction to clinical reasoning and answer the following questions. What is it? Why is it important? And how can nephrology educators help learners improve their reasoning skills? First of all, it's important to recognize that medical errors are a significant source of morbidity and mortality. Diagnostic errors are the most common type of medical error. And it's estimated that between 40 and 80,000 deaths a year are attributable to diagnostic error. Research has helped identify factors that are responsible for diagnostic errors as well as their prevalence. The least prevalent type of factor is something called a no-fault factor, which includes when a patient gives misleading information or erroneous information to a clinician. This is then followed by system-related factors, which may include technical failures, equipment problems, or organizational flaws. The second most prevalent type of diagnostic error based on cognitive factors, which include faulty knowledge, faulty data gathering, and faulty synthesis. And then a combination of both system-related and cognitive factors are the most prevalent factors that lead to diagnostic error. Cognitive-related factors or errors, as we said, are related to faulty knowledge, faulty data gathering, and faulty synthesis. Together, these three things are fundamental to the process of clinical reasoning. So what exactly is clinical reasoning? Clinical reasoning is a process in which clinicians gather data, interpret data, and synthesize data to come up with a diagnostic and management plan. Researchers have proposed a pathway to describe the clinical reasoning process. That pathway begins with the step of data gathering, which then informs hypothesis generation, followed by something called problem representation. A problem representation is a 1 to 2 sentence summary statement that highlights the salient features of any clinical case or problem. In other words, it is the one-liner that is often used on rounds to characterize a patient's main problem with features including demographic data, temporal data about symptoms, and important physical exam and diagnostic tests. The problem representation triggers something called illness scripts. And illness scripts are groups of symptoms and associated diagnoses that are generated, stored, and refined over time in clinicians' memories. Illness scripts are again activated by the problem representation, and together this becomes the platform by which the subsequent steps of the pathway are built. This means that the problem representation and the associated illness scripts will help develop a differential diagnosis that will be prioritized, by which ultimately a working diagnosis will be selected and a management plan will be developed and activated. This pathway is fed by two cerebral processes. The first is a non-analytical process, which is unconscious and relies heavily on pattern recognition, or as we described, illness scripts. Often, the non-analytical pathway or process, often described as System 1, is used by very experienced clinicians to come to rapid decisions about patient care. The other process is an analytical process. It is conscious, it is deliberate, and it often involves comparing and contrasting potential diagnoses in a systematic way, prioritizing them based on the data observed from the patient's history, exam, and diagnostic tests. This is often used by novices or by experienced clinicians as a check against cognitive biases that can sometimes arise when relying on System 1 or the non-analytical process. Therefore, System 1, also known as the non-analytical process, and System 2, also known as the analytical process, together define dual process theory of clinical reasoning. Therefore, it is critical to note that while medical knowledge is absolutely necessary to perform successful clinical reasoning, it alone is insufficient to ensure that clinical reasoning is sound. Also, it is important to note that reasoning is vulnerable to a variety of cognitive biases. These are some examples of cognitive biases, and there are approximately 40 that have been identified by researchers and are published in the literature. So how do we improve clinical reasoning skills to reduce diagnostic error? Experts in medical education propose that we teach the clinical reasoning pathway explicitly to learners, and also teach our learners about common cognitive biases that can predispose to diagnostic error. This means we need to train faculty to recognize learners with deficiencies in clinical reasoning and to train faculty to coach these learners to improve their clinical reasoning. That is why we are developing reasoning evaluation in nephrology education, also called RENE for short. The goals of RENE are to provide valid tools to assess clinical reasoning skills in nephrology learners. Currently, there exists no validated tools to assess this, and most of our assessment tools measure knowledge alone. And again, we know that knowledge is absolutely fundamental to the process, but insufficient. We also would like to ultimately provide a structured feedback framework so that nephrology educators can use this to coach learners in clinical reasoning. Thank you very much for listening to this short video. We hope you learned a bit about clinical reasoning, and we are excited to have you explore our website and participate in reasoning evaluation in nephrology education.